see, so see, when you get a dissect upper limb, this is pectoralis major and this one is pectoralis minor, but they are not usually tied. Okay. Then see, as you know, this is serratus anterior, attached to medial border of the scapula on the costal surface. This can be tied, or the subscapularis. This is subscapularis. So this is subscapularis. That is attached throughout the subscapular fossa, and that can also be tied. Okay. Then this thing you get over here, the deltoid. That is a very common tie structure. They ask about its insertion, that is into deltoid tuberosity, or they ask for knot supply, that is axillary nerve, or they ask what is its clinical or applied importance, that is intramuscular injection. Sometimes they may ask what type of muscle it is. It is a multipinal muscle. Deltoid is a multipinal muscle. Okay. Then see over here, multipinal muscle. Now see over here, this is the front of the arm, that can be full window, where you get three muscles mainly. See, this is the biceps brachii. Bi means two head. So here there are a long head and there is a short head. Remember, long head is lateral. So out of the two heads, this head that is towards the lateral side is long head and this head is short head. Okay. Nearby the short head, you get another muscle that is called coracobrachialis. This is the coracobrachialis. This one is your coracobrachialis. That is nearby the short head, and that gets pierced by the musculocutaneous nerve. Okay. So musculocutaneous nerve you identify because it pierces coracobrachialis. Coracobrachialis you identify because it pierced by the musculocutaneous nerve. Musculocutaneous nerve can be tied. Okay. Then see, the third muscle is brachialis that you get if you lift the biceps. If you lift the biceps, dip to that. See this muscle, this one is your brachialis. This muscle is brachialis. Okay, that you simply get by lifting of the biceps brachii. When they tie the brachialis, see, they again ask two common questions regarding it. First thing, what is it knot supply? It has got dual knot supply. Medial side by musculocutaneous nerve, lateral side by radial nerve, and the radial nerve is carrying proprioceptive sense or position sense from this muscle. Okay. Or they ask the insertion, one word, ulnar tuberosity. You may write like the tuberosity in front of corner prosomna, or you can simply write ulnar tuberosity. That will also give you the requisite mark, articulation spotting. So these three muscles you need to identify. Then see this structure. This one over here. See, this structure is the brachial artery, but if they tie it here in middle of the arm, it is brachial artery. If they tie it up above in the axilla, it is axillary artery. Okay. So they may tie either, and accordingly they can set the cases and give the branches. And if they tie the axillary artery, they ask how it is divided three parts by the muscle, pectoralis minor, or what are the branches from first part, second part, third part, like that. But a more common spotting is tying the brachial artery, and they usually ask what are the terminal branches. That is radial artery, ulnar artery. You can find that this is radial artery over here, and this branch over here, this is the ulnar. This is ulnar artery, and this is radial artery. Very easy. Radial artery towards side of thumb, ulnar artery towards side of the little finger. Okay. Then you see over here, we can find a vein over here. See this one. This vein is the basilic vein. Okay. That is continuous upwards as the axillary vein. So if they tie it here, it is basilic vein. But if they tie the same vein in the axilla, it is axillary vein. See, this is the same vein. Okay. Same vein nostrum. If they tie it in the middle of the arm, it is basilic vein. If they tie it in axilla, it is axillary vein. But the more commonly tied vein is this, the cephalic vein. Okay, this one, the cord structure that is usually present in deltopectoral group. Who identify the cephalic vein because of its location. It is in the group between the muscle pectoralis major deltoid, and accordingly this group is called deltopectoral group. See, cephalic vein, basilic vein both begin from the dorsal venous arch. The basilic vein begins from the medial side of dorsal venous arch and is continuous upwards on the medial side. That is continuous further upwards on the axillary vein. But the cephalic vein begins from the side of thumb, lateral side, ascends from the lateral aspect of the upper limb and drains into axillary vein. So have this thing in mind. Basilic vein is continuous upwards to axillary vein, but cephalic vein drains into axillary vein. This fact is acts in numerous fashions in numerous questions, but the information is same. Okay. Now see. Now let's see the nerves. So see, this nerve is the median nerve because it is present in the middle, and you can find two roots fusing to form it. So this is lateral root, this is medial root. The lateral root of the median nerve starts from the lateral cord of brachial plexus. So if you hold the lateral root and go above, you find the lateral cord. So this is the lateral cord. Okay. From that, this vein beginning is this nerve beginning is musculocutaneous, that is piercing the muscle coracobrachialis. Okay. Then see, similarly, this is the medial root of the medial nerve. If you get hold of that and go above, you find the medial cord of brachial plexus. From the medial cord, see this nerve that is starting. This nerve is going behind the medial epicondyle. It's a medial epicondyle, and this nerve is going behind that. So this is ulnar nerve. When they tie the ulnar nerve, a very common side question is what is root value? Root value is C7, C8, T1. Okay, and see over here, you can find another nerve, very thick nerve. See that is going to back of the arm. You can also locate that here in the spiral groove. This nerve is radial nerve, and they usually tie it at the back of the arm in the spiral groove. This is radial nerve, and see over here, there is another nerve. You can find, see this one, see this nerve, okay, this nerve is going towards deltoid, that is axillary nerve. So here you need to know about 5 nerves, median, radial, ulnar, muscular, axillary, out of which axillary nerve is less commonly tied and asked less commonly about it in the window or in the fiber. So what you need to study in the window of the front of the arm, 3 muscles, biceps brachii, coracobrachialis, brachialis. You need to read about the basilic vein, you need to read about the brachial artery, you need to know 5 nerves, median, radial, ulnar, musculocutaneous, axillary. Okay, then the window is complete. We go to the next window, that is the back of the arm, where there is only one muscle, that is triceps. It has got 3 heads, tri means 3, long head, lateral head, medial head. See this head that is coming from the scapula above, this one is the long head. Okay, and the cut head here is lateral head, that is arising from above the spiral groove. So this is the radial nerve indicating location of spiral groove. Above that arising, this is lateral head, and below the spiral groove, this deep head is medial head. Okay, and when they tie the triceps, they tie it here, so that the answer to the spotting is entire triceps and not a single head. They never tie a single head at the spotting. Okay, then see there is only one nerve here, radial nerve, and only one vessel, that is profunda brachii vessel. This, apart from this thing, what they can ask in the R is the radial nerve in the spiral groove. They may ask anything about radial nerve from its beginning to its termination, like it begins from posterior coracobrachial plexus, is located in axilla, then goes to back of the arm, there it is placed in the spiral groove, then it again pierces the septum to come to the front of the arm, where it divides into 2 branches, superficial branch and deep branch. Superficial branch accompanies radial artery and goes forward, but the deep branch is the posterior viscous nerve that pierces supinator and goes to back of the forearm. Okay, and there they may ask about what are the branches of the radial nerve above spiral groove, what are the branches in the spiral groove, what are the branches below spiral groove. So what are the branches above the spiral groove? Both muscular and cutaneous. Muscular branches are to long head of triceps and to medial head of triceps. What is cutaneous branch? See, if the radial nerve is here in the spiral groove, just imagine its course above the spiral groove. So the cutaneous supply is the back of the arm. That's what the nerve is called, posterior cutaneous nerve of the arm. Then when it is in the spiral groove, above it there is lateral head, below there is medial head. So 2 branches are, one to lateral head, one to medial head, and the branch that supplies the medial head also supplies the muscle anconeus. And when it is over here, it gives 2 cutaneous branches. One is lower lateral cutaneous above arm, and one is posterior cutaneous above forearm. Then what are the branches below the spiral groove? That part gives only muscular branches, no cutaneous. During its course below the spiral groove, it passes in such a way that on the medial side there is a muscle brachialis, on the lateral side there is brachioradialis, and extensor carpi radialis longus. And here the branches are to these 3 muscles. Okay, so what are the branches of the spiral of the radial nerve below the spiral groove? Only 3 muscular branches. They are to brachialis, brachioradialis, and extensor carpi radialis longus. No branches are given to the cutaneous of the skin. Okay. Then this is not a very common question, but sometimes they tie it. Probability of the mood of the examiner, sometimes they put it as a window, sometimes they don't put it. Okay. Then also read the triangular space and quadrangular space as a window question, so it is very easy to remember. See, this is the pattern. Okay, teres minor, teres major. This is long head of triceps, and this one is the humerus. Above the cervicalis, below sap. So see, this is the upper triangular space that is bound by teres minor, teres major, and long head of triceps. What passes here? Circumflex scapular vessel. This is the quadrangular space. Over here, you can look from the shape, above teres minor, below teres major. Then this is long head of triceps, and this is cervical neck of humerus. What passes here? Same structure which are at the cervical neck of humerus. Axillary nerve and posterior circumflex humeral vessel. So you can mark the lower triangular space. What are the boundaries? Teres major, then is long head of triceps, and this is shaft of humerus. What are the content? Same as the content of spiral groove, radial nerve and profunda brachii vessel. So that is if it is a window, triangular quadrangular space, that is mostly theory. They don't ask you to show it because there you need to loosen a lot of muscle to expose these three spaces. Okay. Then see the next window is the cubital fossa. The cubital fossa, you know everything about this boundary content. See, this is the medial boundary. This muscle is pronator teres. Pronator teres can be tied as well as spotting. And lateral, this is brachioradialis. At the base, there is the imaginary joint to epicondyles, and apex is formed by the convergence of the medial border, lateral border. On the floor, the two muscles, ebobrachialis, below supinator. What are the contents? MBTR. Instead of remembering MBBR, remember MBTR. Okay. So see the medial most. This one is the median now. Then this is the brachial artery. This one is the brachial artery. This is tendon biceps from which what is emerging is the bicipital aponeurosis. So that is over here. This prolongation, quite short one here. Okay. Then see, this is the superficial branch of the radial nerve, the fourth content. See over here, this thing is the trunk of the radial nerve. Okay. Underneath which I put the forceps, this is trunk of the radial nerve, and from it what is emerging, this is superficial branch that is on the lateral aspect of the forearm. And see this one. This is your deep branch or the PIN, posterior interosseous nerve, that pierces the muscle supinator and goes to the back of the forearm. So if they ask you to identify the supinator in the window, don't hesitate, because you get hold of the deep branch of the radial nerve that passes immediately into the muscle supinator. Okay, that passes immediately into the muscle supinator. Okay, so then what is left is the forearm. But see, in the back of the forearm, all they ask is the spotting, that is extensor retinaculum. So read everything about it, attachment, what are the 6 compartment, 9 muscles in it, and particularly lay focus on the 4th compartment. Okay, where 4 things pass, that can be asked as a spotting question. But details about the back of the forearm muscles are not asked. That is not a window here, at least here in AIIMS Bhubaneswar, in SCB, they put it as a back of the forearm as a window, but they don't put it here. So what is remaining is front of the forearm, that is the most difficult window from the upper limb. So here you get 5 superficial muscle. So lateral one is pronator teres, my thumb, then flexor carpi radialis, then palmaris longus, then flexor distal superficialis, then flexor carpi ulnaris. Okay. So if you identify them, if you are having any difficulty in finding the pronator teres, simply find the cubital fossa, go to its medial boundary. So this muscle will be pronator teres. See, it is ending midway in the middle of the forearm. Okay. So this one is your pronator teres. Then on the lateral side, this is brachioradialis. This is the apex formed by the convergence of the two borders of the cubital fossa, but that is not a question. So this is pronator teres. Then see, from there go medial. Never go lateral. You will get nothing. Okay. So if this is pronator teres, immediate next muscle is flexor carpi radialis. This muscle is palmaris longus, short belly long tendon. Now see, the palmaris longus is continuous downward at the palmar aponeurosis. Okay. Then this muscle is FDS, flexor distal superficialis, with multiple tendons, and this one is your, this thing is your flexor carpi ulnaris. Okay. What are the 3 deep muscles? Flexor profundus, flexor pollicis longus, and pronator quadratus. So see over here, this band-like muscle is pronator quadratus. Pronator quadratus. This muscle with multiple tendons is FDP, flexor profundus, and see this muscle. If I am tugging at this, the thumb is getting flexed. So this is FPL, flexor pollicis longus. But remember, this relation may be always there. This tendon is not midway, and there upon tugging the muscle, the thumb may not be flexed. Okay. Now see over here. See this. This is the interosseous membrane, the membrane-like structure, and in front of it, this thread-like structure is anterolateral nerve, and this one is anterolateral artery. Okay. You see over here. See this membrane-like structure, interosseous membrane, and in front of it, this one is your anterolateral nerve, and this one is anterior interosseous artery. Okay. So they may tie the interosseous membrane, ask what is the function. It connects radius to ulna, transmits weight, gives attachment to the muscles of forearm. Or simply they may ask what it connects. It connects radius with ulna. Sometimes they ask what is the duration of fiber. Very rarely, that is like you put your hand in the trouser pocket, downward, forward, medial. Okay. Then if they tie the anterior interosseous nerve, they ask in the branch of which nerve, median nerve. Or if they tie the anterior artery, it's a branch of which artery. Direct branch of common interosseous, that in turn is a branch of the ulnar. Okay. In this spotting department, they can tie pronator quadratus most commonly, or the pronator teres. Others are not usually tied, but here you get many other nerves and vessels apart from this. See, this is your flexor distal superficialis. See, plaster to its under surface. This is FDS. Okay. plaster twist under surface. This thing is your median nerve. Okay. Then on the radial side, you get two things over here. See these two things. Out of them, the cord-like white structure is radial nerve, and this is radial artery. Okay. Then on the ulnar side, you get another two things. See over here. This cord-like structure is the ulnar nerve, and this cut artery is the ulnar artery. Okay. So if they ask the fiber of the window here, they will ask the name of the muscle and ask to identify it. They ask for interosseous membrane, anterior to the artery, anterior to the nerve, or they may ask about the other three nerves: median nerve, radial nerve, ulnar nerve, or these two arteries, radial artery, ulnar artery. And for them, you read the extent, where they begin, where they end, at least in the front of the forearm, and read some of the branches given here from the artery and the nerve. So that is all that usually asked. But sometimes the examiner may pick a single muscle and ask everything about it. Particularly, they ask what the insertion of flexor carpi ulnaris. Most of the fibers go to pisiform bone. From there, fibers extend to fifth metacarpal and the hamate, giving rise to piezo-metacarpal ligament and piezo-hamate ligament. So the insertion of FCU, flexor carpi ulnaris, is usually asked. And remember, pisiform is a sesamoid bone in the tendon of flexor carpi ulnaris. Okay. Then in the palm, that is never a window. What they tie is this palmar aponeurosis, and as if it is a remnant of what palmaris longus, or they may ask its function, that is protecting the nerves and vessels below, giving it a compartment that you can write 2 to 3, or they may tie this, the flexor retinaculum, okay, that is divided in the middle. So if they tie the flexor retinaculum, they usually ask the attachment, or what is passing superficial to it, or what is passing deep to it. Remember 4 type structures: passing superficial to it, passing deep to it. So this is that you will get in the window or the spotting of the for upper limb, and the windows and the spottings are same for the PCT, not for the PCT. They don't have the window for the internal as well as for the fast prop. In the fast prop, you are only going to get these window questions and these spottings. Okay, that is the upper limb.
So which is pectoralis minor and
See over here. This is major, this is minor. You can tell it clearly because the largest stump is left from the major and is looking larger. But how to know when it is cut from here? Major, pectoralis major is inserted to humerus, but the pectoralis minor to coracoid process. So the muscle that is attached higher is minor, and the muscle that is attached lower is major. Okay.
So can you please show the pectoralis muscle?
See, that is over here. See, there are 2 heads. Okay. This is long head lateral, short head medial biceps. Then nearby the short head, there is a muscle that is pierced by the musculocutaneous nerve. So this muscle that is fused with the short head is coracobrachialis, and beneath the biceps, this is brachialis. See, it is very easy. Suppose biceps, lift the biceps. Beneath that, you get the brachialis.
So this one is the brachialis.
This is the brachialis. This is the brachialis. Okay. Brachialis. Okay.
And near the short head, it is the coracobrachialis.
Coracobrachialis. This muscle. Okay. They are fused. Short head of the biceps and coracobrachialis are fused. Medial part is coracobrachialis, lateral part is short head of biceps.
So can you tell about the nerve?
See.
So this one is the musculocutaneous.
This is musculocutaneous. This is median nerve having 2 roots. That is how you identify it.
Yes.
Then see, if you, this is lateral loop. If you get hold of lateral loop and go up, you find the lateral chordobrachial plexus. Beginning from that, this is musculocutaneous. Similarly, if you get hold of the median root or median nerve and go above, you find the medial cord. From that, see this nerve arising. This one, okay. This one is passing behind the middle epicondyle. It is ulnar nerve. And then see this nerve arising is going to the back of the arm. That is radial nerve. They usually tie it here. Okay. They usually tie it here in the spiral groove. Okay. And see, there is another nerve over here. This one that is arising from the same cord of the radial nerve, and it is going to deltoid, axillary nerve. Nearby the axillary nerve, this is the posterior circumference femoral artery. So there are 2 things here. Okay, see, there are 2 things here. 2 things here. If you trace them, see, this is the nerve that is coming from the same cord of the radial nerve. This is axillary, and see, this thing is arising from the axillary artery. This is posterior circumference femoral artery. They are present together. Axillary nerve and posterior circumference femoral artery. But you may not get this arrangement in every specimen, so that is the challenge. In the specimen may be very good like this, or it may be poorly preserved. Many things may be torn and all that. So we have to identify everything there also.
So near the rest you showed interosseous membrane and another muscle also.
So see, quadratus. This one.
Exactly.
See, the interosseous membrane white, but the point of quadratus having brown.
See, and it has an anterior interosseous.
See over here, in front of the interosseous membrane, This white structure is anteromedius nerve, and this dark structure is anteromedius artery.
So which one? This
See,
one.
this one. Okay, this one. Okay. Okay.
Anterior interosseous artery, that is anterior interosseous
No.
nerve. So behind it we will having posterior interosseous artery and
Now, in the fourth compartment of the beneath the external reticulum, we have external digitorum, external indices. So this is digitorum, and this one, see, is going to the index with the thumb. So it must be somewhere here. See, this one is going to the index finger. Okay. So this is external digitorum and indices taken together, and deep to that you get here posterior interosseous nerve and anterior interosseous artery. Okay. So that is not very clear over here.
Sir, in the Viva they will just ask from gross, or we have to.
No, in the Viva, question tells you the answer. Suppose what can be the question? Window, they ask you, read the cubital fossa and answer the quiz. Or read the viscera probator and answer the quiz. So, for the window event, or for the spotting obviously, you have to read only the dissected upper limb. The parts that are available here, or the heart and lungs in the thorax, for supras and thorax. Details will be asked only related, like suppose they are asking you the heart, right atrium, development of right atrium. Okay, or if heart is studied at the very end, they may ask the development of all the four chambers or some anomalies like tetralogy of Fallot like that. But that is not. I don't think heart is covered in embryology. Okay, so that is the thing. So when you read for the practical, read according to question. Read the slides that can be asked as spotting. There you have to remember only two character picture, or read those slides which can be asked as commenting. There read everything about the histology. There is no need to read glands and the desmosome, all that. Okay. Similarly, in the embryology, now many things may not be asked. So, and if you think that you are going to read general embryology, the fetal membrane, everything, that there nobody will ask regarding that. The general embryology, fetal membrane, blastocyst, gastrula, nobody will ask about that. Okay. Then also in the general anatomy, will not be asked. Nobody will ask about end artery or knobs, classification knobs, unipolar bible. That is for the theory. Okay, but what they can ask, suppose a bone is there. What type of bone? Long bone. Give some other example of long bone. Or this is irregular bone. Give some example of irregular bone. Suppose they are holding the clavicle. So it forms two joints, sternoclavicular, acromioclavicular. They ask what type of joint it is. Suppose you answer sternoclavicular joint, saddle type of joint. Then they ask, give some other example of saddle type of joint. This way things are asked. In the Viva, one question leads to other. So there is no need to read details about general anatomy, histology, embryology and come to the exam. First read what can come as question. Then also the bones, you read the main bones first. Humerus, clavicle, scapula, radius. Ulna is asked a bit less. Carpal bones won't be asked here after the first internal. Similarly, in the thorax, read the sternum, very commonly asked. Typical thoracic vertebra only. The rest of the vertebra can be asked as theory, but they don't ask that, they don't show you a 10th thoracic vertebra and ask to identify it. All they need to identify is typical thoracic vertebra. Or read the ribs, which ribs? Typical rib, first rib. See, they can ask a bit about second rib or about 11, 12 rib, but nobody is going to ask details. What they ask in detail? Typical rib, first rib. Okay, so you first read the question, read the dissected part, read the heart, lungs, read the bones, then go to the other parts, but if necessary. Okay, nobody is going to ask you like this, classify the joints, and if they are asking you, that means they have already made sure that you are a very good student. So they want to test your knowledge. And but then you show some of the examiners throw caution to the wind, and the very first question is classify the joints. That is the thing. But usually, suppose this is a window. Okay, so they will ask you to identify the structure, then ask details about those structures only.
So window is like cubital fossa.
Window में front of arm, back of arm, cubital fossa, front of forearm. Usual window question. Sometimes they ask the triangular quadrangular space or radial nerve is spiral.
Radial nerve and spinal.
And heart and lungs can be window. They would put a heart or put the right lung or left lung and ask as a window. Okay.
तो स्पॉटिंग में जब बोन को कलर किया जाता है, वो जब मतलब सेकंड या थर्ड ग्रुप आता है, वो कलर छूट जाता है, तो पता ही नहीं चलता कौन सा कलर.
मतलब so it is not properly colored, but that happens if the color is given just before the exam, because the student can't touch it and the color goes on. But if they give the paint half an hour before the exam, then that doesn't usually happen. Then this is also your fault. Suppose one part is pointed. What is the use of rubbing it? What is the use of rubbing it? You are saying that this is this bone, okay. To determine the side you need to hold the bone. But why you need to rub the collar? That comes up. Why do you need to rubbing the collar? That comes up. You need to hold it and
Sometimes I see two colors.
Yes.
Yes, उनको थोड़ा
One green,
अच्छे से
one
paint
pink.
होता
The
है।
one which is very prominent is painted. The
she is
one.
intelligent. None of you are. So that thing will happen. You may get a specimen where everything is eaten up by the mice. So thing is there, you have to also manage with that.
So can you once again tell me?
Pura, see, this is one terrace.
So this one,
Okay.
yes.
Let me finish. The flexor carpi radialis,
So this one is pronator teres, flexor
Carpi
carpi
radialis,
radialis, and this is the
palmaris longus, yes.
then flexor carpi
digital superficialis. This is the carpi ulnar.
then flexor carpi ulnaris.
So this is Jupiter terrace.
Pronator teres,
This is carpi radialis. Palmaris longus. This is FDS.
FDS.
Flexor carpi ulnaris. Then deeper this is FDP. This is pointer quadratus. And this one is your flexor pollicis longus. Okay.
So flexor pollicis
Longus. FDS. Now what is
पीछे देखी नहीं है मैं चाहे
Okay, let me identify once again. Just come. So those who
Side
are
हो
cis,
जाओ यार,
please
चिपका हो गया,
go. And those who are not cis, please come.
शेयर वाला मैंने करा
At least interval नहीं पूछी